I'd like to acknowledge the Wiradjuri people whose land this meeting is being held at today. I would also like to show my respect to both elders past and present. Thank you.
Thank you, Sky, for that welcome to country. With us this afternoon are the Minister for Health and Minister for Health Research, the Honourable Gillian Skinner, who has invited us all today, the Honourable Melinda Pavey, MLC, Parliamentary Secretary for Regional Health, Dr Mary Foley, the Director General, New South Wales Health, Dr Robin Williams, the Chair of the Western New South Wales Local Health District, and Ms Lynn Weir, Director of Operations, Western New South Wales Local Health. We have apologies from the Honourable Kevin Humphries MP, Minister for Mental Health, Minister for Healthy Lifestyles and Minister for Western New South Wales. As you can imagine, due to the recent floods, he's been detained elsewhere and regrettably he's unable to attend. He has advised, however, that he would really like to hear from anyone with a view about our mental health services in Western New South Wales, how we can improve those, and he asked for ideas, and anyone who would like to share their thoughts to contact his office. We also have an apology from Ron Dunham, the Chief Executive of Western New South Wales Local Health District, who unfortunately couldn't be here tonight and he really wanted to be here. Now, just a few housekeeping matters before we start. We all love those jingles of the telephone, but they tend to disrupt proceedings. So I just remind you, if you could just put them on silent for the duration. I'm usually guilty halfway through a meeting, there it goes. Also, just for those who are not sort of used to the RSL, the toilet facilities are just as you exit at the next corridor just to the right. Now, just so we all know how the proceedings are going to proceed tonight, I just want to give you a brief overview. Dr Robin Williams will open this forum, providing an overview of the activities, successes and plans for the Western New South Wales Local Health District. Following Robin's presentation, Minister Skinner will outline the government's health agenda, its performance against its election promises and its achievements. After that, you, the forum, and the members here will have an opportunity to pose the questions to the Minister and, in fact, anybody in the panel. We will take questions from the floor, but there's also quite a few questions which have been sent to us by email and other means. Depending on how the questions are going, and I imagine with this sort of audience we'll have lots of questions, we'll take a short break, needed to be about 7 o'clock, and then reconvene, or if it looks like we're going to, there's not many more questions, we might continue until we finish. But we'll play that by ear and how we're going. To conclude this evening's forum, later on, Mr Troy Grant, the local member for Dubbo, will provide the closing remarks. For those who have a question, but would like it answered outside this forum, you can lodge your question at the registration desk we came in, or via email. And this is important, we also have with us the Acting Complaints Manager for our local health district, Mrs Beth Maslim, and she'll have a table set so that if you have specific clinical type questions and typical problems, we can address them that way. We can assure you that they will be addressed, that the Minister will be alerted, and I'll make sure that that will happen. And nothing that will be done in that question. With us, we also have nearly all the members of the local health board, and it's an opportunity for you to let them hear what you think is needed and how we can progress this. And I'll just mention Daryl McKenda, Julie Marr, Joan Sawicki, Dr John Turth, Ms Pat Durlan and Mr Jeff Mann, and an apology from Scott Griffith. So you have a great opportunity for you to give the message to the people that will listen and hopefully we'll do something about it. So without further ado, I'll ask Robin Williams to open the forum with his presentation on the work and the successes of our local health district.
Good evening. Can you hear me? Yeah. No? Good. How's that now? I'd like to begin by acknowledging the Honourable Gillian Skinner, Minister of Health and Minister for Medical Research, the Honourable Melinda Pavey, MLC, Parliamentary Secretary for Regional Health, Dr. Mary Foley, Director General, New South Wales Ministry of Health. I would like to show my respect and acknowledge the traditional custodians of the land, of elders past and present on which this meeting takes place. Ladies and gentlemen, good evening and welcome to the Western New South Wales Health Forum. We are delighted to host the first regional health forum at the invitation of Minister Skinner and to welcome so many representatives of the communities we serve. Today is a significant one and a historical one. Tonight, the New South Wales State Government has provided an opportunity for you to have input into how health services in our local health district can be more focused on what you need. The Minister for Health and her esteemed colleagues are here with open ears to listen. I'm Robin Williams, Chair of the Western New South Wales Local Health District, which formed on the 1st of July 2011 and is one of the largest rural health districts in NSW, akin with the area of Great Britain. I'm a GP in Molong and a VMO at Molong Hospital, and together with board members Associate Professor Joe Canlisi, Mrs Patricia Doolan, Mr Scott Griffiths, Dr Daryl Mackender, Ms Julianne Marr, Mr Paul Mann, Dr John Tooth and Mrs Joan Treweek, we are responsible for the strategic leadership of the local health district. The local health district and its board was formed following state government reform, which saw the abolishing of the former area health services and a move to devolve decision-making about the provision of health services closer to the patients. It is no secret that our local health district is geographically very large and faces many challenges unique to rural areas in accessing healthcare. I'd like to give a brief background on the LHD to set the context for this evening. The Western New South Wales Local Health District serves an estimated population of just over 266,000 people, which is 3.9% of the New South Wales population. The population is dispersed across the area the size of England, Scotland and Wales, and contains 23 local government areas. 7 of these LGAs are classified as remote or very remote. Most of the population is concentrated in the LGAs of Dubbo, Bathurst, Cabonne, Orange, Midwest Regional, Parkes, Forbes and Cowra. There are 38 inpatient facilities ranging from major rural referral health services at, in alphabetical order, Bathurst, Dubbo and Orange, to district health services at Cowra, Lachlan and Mudgee, and multi-purpose services in many towns across the LHD. I think it is important to discuss some of the challenges that face us. People living in rural and remote areas generally have worse health than people living in metropolitan areas. Compared with people who live in major cities, people who live in remote areas can expect to live about 5 fewer years, are more likely to die early and from causes classified as potentially avoidable, report greater difficulties in getting health care when they need it, are more likely to be hospitalised for conditions for which hospitalisation can be avoided through prevention and early intervention, are more likely to be overweight and obese, are more likely to be hospitalised for heart disease. I would like to talk about mortality or death. Life expectancy at birth is 77 years for females and 76.9 years for males. Both these figures are significantly lower than the New South Wales figures of 84.4 years for females and 79.6 years for males. Leading causes of death are cardiovascular disease, chronic obstructive pulmonary disease, cancer, the highest being lung cancer, fall-related injury, poisoning, and diabetes-related conditions. Death rates of people living in Western New South Wales Local Health District vary by local government area. Differences usually reflect the level of remoteness and the proportion of Aboriginal people living in the LGAs. Generally, people living within the Western New South Wales Local Health District have significantly higher levels of potentially avoidable deaths. Deaths attributed to smoking and alcohol, and deaths from cardiovascular disease compared to the rest of New South Wales. From mortality, we move to morbidity, or sickness. Residents of the Western New South Wales LHD have significantly higher levels of hospitalisation attributable to being overweight, smoking and alcohol, and hospitalisation for cardiovascular and respiratory disease. These realities are married with difficult challenges in dealing with them, including an ageing workforce, difficulties in attracting, recruiting and retaining doctors, nurses, midwives, allied health workers, increasing demand for services, a rising cost for maintaining services and escalating community expectations. We have a complex problem on our hands. But this is not all doom and gloom. We live in a fantastic, clean, safe area of the world, and compared with the vast majority of our peers overseas, have much to be grateful for. But we still need to make things better for our communities in closing the gap in health between ourselves and metropolitan areas of the state, and in particular in closing the health gap between Indigenous and non-Indigenous members of our community. And for this, we must have a robust, evidence-based strategy for the future. The Western New South Wales Local Health District Board has welcomed the opportunity to take the Minister for Health's vision to devolve decision-making on health closer to the patients, and we take our responsibility very seriously. We see that there are several opportunities for the Western New South Wales Local Health District to overcome some of these challenges. Engagement with our communities and our clinicians is one of the most important steps in achieving this goal. We aspire to become leaders in delivering accessible healthcare. The Board shares the Minister's vision to establish strong foundations for the planning and development of all health services through robust community and clinician engagement, through the network of health councils and clinical councils. The Western New South Wales Local Health District Board understands that to ensure we have the best systems in place, that we need to look at mechanisms for advancing partnerships. Some we will need to develop as new organisations, such as the Medicare Locals evolve, and some existing ones that we need to build upon, such as with Aboriginal health services, private providers, universities and other education facilities. We need to be transparent. Whatever we try and do, we must remember the person at the core of our efforts, our patients. So the Board's strategic vision for the future includes taking ownership for the poor status of health in our local communities. We acknowledge that we need to be more proactive in sending health promotion messages to the community, to have a plan to work closely with the Medicare Locals and engage our partners more effectively. The strategic vision includes matching need to service delivery. We know that we must listen to our patients, our clinicians and our communities to understand how to provide equity of access to services throughout the district. Developing clinical networks is a priority, in particularly starting with cancer and diabetes networks because they are so crucial in this LHD. We must promote the district as a whole entity, formalise specialist linkages within and outside the district, so that we can present the district as a sound organisation and gain more efficient control of resources. Workforce planning is of utmost high priority. We have an ageing workforce, with difficulties in attracting and retaining health professionals, and the high cost of agency and locum costs are of great concern. The Local Health District Board has recognised the need for immediate action and strategies to address workforce challenges. The Board acknowledges the relevance of other service providers, regardless of size, in assisting the Local Health District to make services more accessible and to avoid duplication. Importantly, I stress again that our linkages and partnerships with universities and education providers are vital, and the Board recognises that the Local Health District can harness the rewards of these relationships in more fruitful ways. We are driven by keeping to core values of collaboration, of openness, of respect, and of empowerment. The Western New South Wales Local Health District Board is led by the principle that we should have safe, high-quality clinical practice, provide services as close to where people live as possible, and have a sustainable approach to the delivery of health care. This triad is paramount in our strategic thinking. We are all here tonight because health is an issue that affects everyone, regardless of how young or old you may be. This forum is a unique opportunity to voice your concerns, raise questions, and make suggestions. So, you are invited to let your voices be heard and counted. We are here to listen. Thank you.
Thank you very much indeed, Joe. May I first of all thank Sky for her warm welcome to country and also acknowledge the traditional owners of the land, pay my respects to elders past and present. I also wish to acknowledge my parliamentary colleague Melinda Pavey, the Parliamentary Secretary for Regional Health. I wish to acknowledge my other parliamentary colleagues Troy Grant, member for Dubbo, Andrew G, member for Orange, also Dr Mary Foley, the Director General of the Department of Health, Dr Robin Williams, the Chair of Local Health District, Lynn Weir, who is the Acting Chief Executive of the district. I want to also acknowledge the Mayor of Forbes, Phyllis Miller. You're here somewhere, Phyllis, I understand. Welcome. And Richard Mutton, Deputy Mayor of Dubbo. There are many other councillors. I wish to welcome and acknowledge you. Also, all of those who've come from the various health councils representing the smaller communities outside the district, outside Dubbo, all of the members of the board. It's so thrilling to see so many of you here. I'm really pleased that you're here. Also, the many staff members from not only the Western New South Wales district, but also the Ministry for Health. You're right, Joe, and I want to acknowledge you and thank you very much for agreeing to be the Master of Ceremonies today, because I know how much you're respected in this community. Can I tell you a story? When I first met, I'm terrible at telling stories, but here I go. When I first met Joe, he had something to do with the clinical school here, and it was a very brief meeting, and he said, look, if you ever become the minister, just do one thing for me. Could you give me double the time for these students out here? And I said, sure, what's that for? And he said, I can marry them off then. So I've always had a soft spot for Joe Canalisi ever since. I think they do that now, Joe, and some of them do get married. But I also want to thank all of those people who've welcomed me over so many years. And Joe's correct. When I became the minister, that very week, the first hospital I visited, and I'm delighted to say I was accompanied by the Director General, who became the Director General the same day as I became the Minister, and we came out to Dubbo Hospital. It was a fantastic visit. We met many of the staff members. We took much longer than I think the administrators thought we should, but that's how I like to visit, to do things. Spending a lot of time talking to people on the ground, because if you don't talk to people, you don't get it right. And really, that's the basis of this forum. I know that that we've got great challenges, Robin. You've been very clear in outlining many of them. But I think that what we're doing, and certainly this last couple of days I've been at Broken Hill and Wilcannia with Mel and others, with the flying doctors, and they flew us to Wilcannia, and they've got a representative from the board here tonight. One of the things that I'm noticing is that devolution, that giving local people a much greater say in how they address the issues in their local area, really means that they've got a much more flexible approach to getting things right. And I think that's going to pan out over coming years to be the way that we move in the future. So if I had to summarise my vision for health, it would be about patients are the centre of attention. Everything should be patient-centric. Anything we do is designed to provide better care for patients and keep people well and healthy. I want clinicians who are happy, and by clinicians I mean doctors, nurses, cleaners, cooks, anyone who has anything to do with the health system, whether in a hospital, a community health service or anywhere else. I want them to be happy, fulfilled and jumping for joy at the idea of coming to work, because they'll know they'll be able to treat people the way they should. And I want people to be realistic in expectations about what we can do. We've got to work together in collaborative partnerships to make sure we spend our resources in the best possible way. First of all, to prevent ill health, to keep people well, to manage chronic illnesses so we don't end up with people unnecessarily hospitalised, but when they do need hospital treatment, to provide it in the most effective way possible. And I believe we should try to do that wherever people live. And I've been really impressed with some of the work of the flying doctors. I've been with them many times in the past, but particularly in this time where we've got floods. And I've just come from, and they've said, I can say today, if anyone's out there isolated with a major health problem, they're there to help. And that's the kind of partnership and collaboration that I think we can all benefit from. So I look forward to hearing what you have to say today. I will answer if there are any particular questions that I feel I can answer. I'll take on board all of your comments. And there are people in the room, if you've got specific concerns, you don't want to raise them, you can go to them directly. And also some of the people from the Western New South Wales district will answer questions, or the ministry. Thank you very much indeed for coming. It's great to see so many of you here.
The next question is from Judy Jenkins.
Yes, my name is Judy Jenkins, and I'm a volunteer at the Royal Flying Doctor Service, and many, many moons ago, a member of the Legislative Council of New South Wales. Minister, as you're aware, the RFDS has placed a second aircraft in Dubbo to meet the ever-increasing needs of this service in central and western New South Wales. The capital costs of these aircraft were met by the Commonwealth Government and the generous support of RFDS donors. Considering the enormous support in Dubbo for that second aircraft, will the New South Wales Government now commit to providing the necessary funds to meet the standing charges and hourly flying rates to enable the second aircraft to continue operation out of Dubbo?
Thank you, Judy. May I welcome you? I should have acknowledged your presence earlier. It's terrific to see you here. Thank you. As I said earlier, I had a very informative day and a half with the flying doctors, Clyde Thompson. We went to the base at both Broken Hill and Dubbo. We spent some time talking to them about the 4 contracts that they have across the state, in Broken Hill, Dubbo, in Sydney at Mascot, and also at Bankstown. We have agreed that we'll put Clyde Thompson, the Chief Executive, in touch with the person that is looking at reviewing ambulance services and aeromedical services, so that we can address some of the issues that would lead to a far more coordinated service that actually would address some of the issues you've raised, but going even further. So I'm very hopeful that we can actually do a lot more for the public with the flying doctor service through much better contractual arrangements involving both the Commonwealth and the state, and also the fantastic community support that is provided for RFDS. So thanks, Judy.
Can we get Alderman Richard Mutton, the Deputy Mayor of Dubbo?
Thank you, Joe. Minister, may I congratulate you first of all on the initiative of the hospital boards. Great. It was needed, and the general public certainly appreciate that. I want to talk about money and bring it up very, very quickly. In your preliminary budget negotiations for the forthcoming year, what are you looking at in relation to city to regional spending in budgetary terms, in general terms at the present time? Is the budget going to be, because we've got 3.9% of the population now here, 3.9% of your budget, or are we going to see more, not only for this region, but for regions generally in New South Wales?
We might ask Dr. Mary Foley to address it.
Is that coming through? Yeah, good. Thanks for that question. As you may know, we're in the process of moving to a new funding model under the arrangements between the COAG arrangements between federal and state governments, and going hand in hand with moving to a more devolved model, we're also moving to a much more transparent funding system, so that which will enable everyone to be able to see transparently where the dollars go and what they purchase. It's generally summarised as activity-based funding, and the model is much more about actually reimbursing or funding health services for what they do. It is going to apply to inpatient, outpatient, emergency department services, subacute care such as palliative care and rehabilitation, and to public mental health services. There will still be the need to have block grants and things like this for particular service areas, particularly for smaller rural and remote hospital institutions, which just have a standing cost to be there, even though their volumes might be light. We're in the process of negotiation nationally about how that's going to work. It does mean that when each district, now that we've delineated them and have local governance in place, for the first time from 1st of July this year, will have a very different looking budget. We're not going to have a huge disjunction from one year to the next, but the budget will actually be much more transparent as to what it's for. The first thing that will do will then highlight lots of questions. It'll raise questions around efficiency, it'll raise questions around gaps when in services, and I would predict then that will lead to a very active process of looking at the resource distribution and whether it's fair, whether it's equal, whether it's buying the right services, and whether we're getting the right outcomes for that investment in people's health. So this is a very significant change, and it will, I would suggest, give our district health board and local leadership more ability to look at the money and to look at how it can best be spent, and also, when we're looking at it from a statewide point of view, looking at the distribution, looking at the gaps. So it'll be a very different way at looking. We'll need to, it'll be about, to some extent, this model is really about the money starting to follow the patient. At the same time, we have to look and make sure that the distribution of services and the distribution of dollars overall is providing a fair, equitable access. And of course, for rural, regional and remote areas, there are particular issues and challenges in doing that. So that's a rather long and technical answer, but it does mean that it will be very transparent, and you will be able to ask very penetrating questions, both at the statewide level and the local level, about how the dollars are being spent, and also it will be very transparent, the comparative dollars. And I think that's going to lead to a very dynamic process in how we look at our health resources.
All right, you mentioned, and I thank you for your answer, but you only briefly touched on the involvement, and this is the crux of all this, the local involvement of boards and how much say they have in attaining money for their budget, and how much, when they get money, how much ability they will have in distributing that money. And this is the crux of the whole thing, isn't it?
Oh, it is absolutely. We will have to each year continue to work within the amount of money that is appropriated each year through the state budget process for healthcare. The government has that based on a growth formula, and then that is still will be distributed out to districts of a annual capped amount, but how that is made up, as I say, will be much more transparent. In this model, it'll be also much clearer that if the work is done, that it is being properly funded at an appropriate level. It will also provide a basis on which local districts can make business cases, and when I say business case, a business case can be about investment that brings health improvement and benefit to the community for additional resources. The process will be a two-way process. It'll be a process of locally identifying need and service development and putting that forward, coming in terms of the budget coming through on a statewide basis as to what the available funds are in any one year, the statewide planning issues, a negotiation, and then arriving at an agreed budget and range of services, and within that there will be the opportunity in terms of growth funding as to what services can be invested in. So it'll be a much more dynamic process than what perhaps people have seen or experienced in the past, and as I keep saying, much more transparent, so people can get much more of a handle on it and have, I'm sure, what will be very robust debate about the allocation of resources.
Thank you. I've got a further question. I might leave it for a little while and give another person a go.
Thank you, Dr. Foley. Elizabeth? Ms. Allen?
Thank you. Can you hear?
Yeah.
That's better. Elizabeth Allen, Chair of the Dubbo Health Council. We've got two comments we'd like to make. One, first of all, is the Dubbo Health Council, representing Dubbo and the Western region, would like a written commitment from the state and federal governments that we will have ongoing funding to complete the rebuild of Dubbo Base Hospital. Stage 1 at 79.8 is a great start, but the job needs to be completed within a short time frame, or we will need to do stage 1 all over again. The other comment I'd like to make is, contrary to some recent negative media comments, not by Dubbo Health Council, we would like to, the Dubbo Health Council, acknowledge the wonderful staff at Dubbo Base Hospital who do a great job, at times in difficult circumstances, owing to the aged part of the hospital. Thank you.
Thank you for those comments. Would you like Minister Skinner to? It's a question that I've often asked.
Thank you very much, and it's good to see you again. You would know that I was out here many, many times as the Shadow Minister, really urging the former government to invest in the hospitals out here, and I'm very pleased that we've got a record amount for Dubbo Base Hospital for their redevelopment. In fact, it went up even after we made the first commitment. I think it's now around about 80 million, 79 million, something like that. Some money from the Commonwealth, and that will start the ball rolling. Now, we've said, and Troy is working very closely with us on this, we'll look at, in the forward capital works, keeping that work going, but we have to balance it right across the state. But don't worry, this hospital is well and truly on the map.
That's reassuring.
Hi, Fiona Rossiter, one of the councillors with Orange City Council. I've got two questions here, but one of which I'll hand over to Dr. Porges afterwards. He'll ask that one. That's to do with the linear accelerator. The other one I've received is from the Arthritis Foundation in Orange, and their letter states that they were promised a pool from New South Wales Government. Their branch believes that there's a therapeutic benefit to having a hydrotherapy pool.
So the question is, what are the plans for a hydrotherapy pool in Orange? Is that?
Yeah, the question is, will they have the funding for a hydrotherapy pool, and if so, would it be a part of the new aquatic centre that's at Orange City Council, with Orange City Council?
Well, let's go. Oh, yes, the hydrotherapy.
Thank you, Councillor Rossiter. I was actually in Orange in December, just before Christmas, with the local member Andrew G. And I met with we both met with the Arthritis Foundation at a forum, which Phyllis Miller was at as well. It wasn't a commitment that was made by our government before the election, and I had a really good discussion with the Arthritis Foundation, and the General Manager of Council was actually at the meeting as well. And there was an agreement to go away, have some discussions with Council and with Andrew G, a state member, to see what the financial cost of it is. Ideally, in a perfect world, while the construction of the improved facilities at Orange Pool, it could be a good time, but we got to government and the cupboard was fairly bare, and we found some money for some long overdue hospital capital works. But the door's not closed on the Arthritis Foundation in Orange, and the Orange community, I think, and you're a very important part of the Orange community in terms of community, has got to work together and come up with some unique solutions for that pool, and we'll support them in those solutions.
Do you have a timeline?
No,
for
I
those
don't.
people?
No, I don't.
And just one more question, and that's with regards to the 24-hour chopper service, retrieval service. Is there an update on that?
24-hour retrieval service.
Retrieval service chopper. And I thank you also for this opportunity.
Thank you. Thanks, Fiona. Sorry, what have we done here? Thank you.
Thank you, Fiona. You'd be aware that, and I mentioned earlier, we're having a review of the aeromedical services, retrieval services, including the helicopter service from Orange, in the context of contracts which are coming due. That will look at future needs of the local facilities and communities. And we're also doing a broader review of ambulance service. We're in fact reviewing the many reviews that have been done into the ambulance service generally. Now, I think the first, we've already started the work, Mary, on the aeromedical service, as we promised you and promised Andrew G. So watch this space for that. And as far as you had a question about linear accelerator? The second linear accelerator.
I'll leave that one for Dr. Porges.
Okay, thanks. But you'll hear progress on the aeromedical review over the next 6 months or so. So thank you.
Dr. Porges, as we could learn. But can I acknowledge that Dr. Porges is a surgeon in Orange, long-standing great service, and in the last honours list he's been awarded an OIM for his work. So congratulations.
Thank you, Joe, and thank you, Minister, Ms. Pavey, who I'm sorry I missed when you were in Orange, Dr. Foley, Dr. Williams, and Robin. Thank you very much for this opportunity. As Joe has mentioned, I am Vice Chairman of Cancer Care West, which is a not-for-profit charitable organisation in Orange, which has had as its prime role developing radiotherapy and an accommodation facility west of the Great Divide. We are extremely grateful for the development of the radiotherapy facilities, and it is functioning very well. I'd also like to thank the Minister for her honoured promise of increasing IPTAS. That has been very much appreciated, and I feel that we need to applaud that. I remember seeing you in Andrew's office, and you said, we're going to do it, and you did. It has made travelling for radiotherapy and cancer treatment much more feasible. As regards the radiotherapy service, we have developed the accommodation facility. The radiotherapy service opened in May. We managed to open the accommodation facility in October. They are both functioning fully occupied. The lodge, the Western Care Lodge, has 14 rooms, and we're already trying to wangle ways of trying to fit everybody in. So there's obviously a need for radiotherapy and the accommodation facility. Currently, as of yesterday, I spoke to the radiation oncologist who has come to live in Orange, Dr. Graham Stevens, and I said, what's the situation? And I quote, he said, we're fully occupied. The radiotherapy unit, the linear accelerator, is currently treating 30 to 35 people per day, and there's a 6 or 7 weeks delay before people can start their treatment. This is unacceptably long, and already this year he could recall at least 6 patients who were referred to have radiotherapy in Orange and had to be referred elsewhere because they could not be started on their radiotherapy regime in a reasonable time frame. As you know, we have a second bunker in the department. I understand that federal funding was offered, and I don't know the fine details, but I do understand that $700,000 is needed to fully fit out that second bunker, even after the cost of that second linear accelerator. The department is working very well. They're a young, enthusiastic group of people who have had a tree change from Sydney. We have a full-time live-in Orange radiation oncologist, and we ask that this urgent consideration be given to fitting out this second bunker. Orange at present is the only single unit, single linear accelerated radiotherapy unit in New South Wales. They have single units in Ballarat, Bendigo and Traralgon in Victoria. However, they all have a hub and spoke philosophy and only 2 to 2.5 hours drive to Melbourne.
I guess, Judy, the question you want is, at what stage are the plans for a possible second linear accelerator?
That's exactly right, Joe. I've finalised now by just saying that, please, can we have a time frame for that second linear accelerator, as it's really getting to an acute stage. We know that it's going to be at least a year before it's installed from the time of funding. Thank you very much, Minister. Thank you, Joe.
I'm happy to address that. As you know, I've had a long sort of history with radiotherapy, and Bob and I and many others in this room were when we were bidding for in the last government, and once Orange was built, we all felt it should be supported, and has been supported in every way. I guess the question is for the second linear accelerator, and the perennial problem of Dubbo versus Orange always arises. From a practical point of view, I think we agree that in the short term, it's more practical to have a second linear accelerator in Orange because of the practicalities of how the radiotherapy runs. The first linear accelerator has downtime, and so you need a second one. The planning for Dubbo Hospital is only at stage 1, and at the moment we haven't got the money for, even if we could get one, both from the feds and from the state, we wouldn't have the money for that. And to me, I think that probably the correct clinical way to go is to push initially for a second linear accelerator in Orange. However, in the plans for the new hospital, because we're working towards that in Dubbo, we should have bunkers ready for when we will have also radiotherapy in Dubbo. As you well know, the way that cancer therapy is going is that intraoperative radiotherapy will be the way of the future. Already there's papers which have been published which show that intraoperative radiotherapy is beneficial in breast cancer and definitely in some intracranial, in some brain tumours. So in the future, I'm sure that hospital, well, obviously we won't have brain surgery in Dubbo, but other forms of surgery will probably be that way. So I believe that my short answer is that I believe we should go for a second linear accelerator in Orange, but plan to have radiotherapy in the future in Dubbo as the new plans for the new hospitals are set in place. Len, is that a fair?
While Lynn is coming, I quite agree that once Orange gets to 2 linear accelerators and it then is an efficient department, at that time there should be the push to have radiotherapy in Dubbo, and with both departments being run linked together to obtain efficiency of appointments and staff.
And as you know, Stuart, Graham already comes to Dubbo and does outreach clinics, so that's already starting to happen. I'm not sure if you're aware, but you know we've put a business case into the department.
Yes.
And we're currently reviewing that business case again to see where we can access those funds. So we are planning to progress as quickly as possible with the second LINAC in Orange.
Thank you very much.
Thank you.
Thank you, Mr. Chairman. Is that all right?
Yes, thank you.
My name is Richard Clegg, and I come from a small town. We've heard from the big towns, but I come from a small town called Tottenham, which is the closest town, the geographical centre of the state. But right now, the town that I represent has a very serious problem regarding the delivery of health and medical services. I know there are other towns with similar problems, but I'm optimistic about how we might be able to resolve the problem. I'd just like to take a short time to give a background to the problem. As an isolated rural town that serves a large district, Tottenham has managed to maintain a reasonably stable town population, but as is the case in most farming regions, the on-farm population has dramatically declined due to technology, larger equipment and financial constraints. Therefore, it has become increasingly difficult just to maintain essential services, which include, of course, health, law and order, education and other services. Of all essential services, there is none more important than health. Tottenham has always managed to support and benefit from the services of a full-time doctor, that is, until recent times, with medical services for the last approximate 2 years averaging 2 days per week. I must add that Western local health district is endeavouring to provide a full-time doctor, but as we know, it is very difficult. Tottenham has to some degree defied the trend by remaining proactive and continuing to improve and add to its community facilities. The reason is simply our semi-isolation, and it keeps the community together. We have amazing community unity. For example, we have a very fine near-new MPS facility, a quality modern open living house for the doctor, a new substantial sports clubhouse supporting the sporting complex and school, and in the last few months, Tottenham community alone has contributed well over $200,000 plus labour and equipment to upgrade our inadequate gravel airport by erecting a new marsupial fence, installing 24/7 CASA solar approved lighting, lengthened the strip, and just this week the strip has been completely sealed. The Lachlan Shire Council have been tremendously supportive with money and expertise and equipment. A truly magnificent achievement. But without a full-time doctor, our new hospital is and will continue to be increasingly underutilised. Staff will leave. People, even locals, will no longer retire to our town.
So the problem is sort of shared by so many smaller units. I think Lynn is actually working. You want to answer that? Or Robin? Yep.
Could I just briefly, Mr Chairman, summarise in what I believe could be a solution?
Thank you. Solutions are better than problems.
Yes, well, I need to outline the background so you understand. But this in turn puts pressure on beds and services elsewhere, as we all know. I'm sure there's no need to reiterate that. In the meantime, our town will decline dramatically and will never recover, which would be tragic. Therefore, it's vitally important for the state's health services, for all concerned, to do whatever we can to... So our number one, number two and number three priority for our community is a full-time doctor. So to finish on a positive note, in order to hopefully find some solution, I believe the solution for doctor recruitment for towns like Tottenham is clever marketing, and I'm suggesting this might include, I've got 3 or 4 bullet points, develop a quality professional marketing program to target prospective doctors, highlighting the town's facilities, services, lifestyle, and especially what can be very lucrative financial benefits, and promote more effectively in appropriate publications, promote through selected social media. For example, 800 to 900 million people look at Facebook every day. But apparently many professionals are leaving countries with crumbling economies. We need somehow to effectively tap into this existing pool, target overseas doctors more aggressively and do everything possible to make Australia more appealing, establish a recruitment fund to develop a marketing program tailor-made for individual towns. I'm almost finished, Mr Chairman. Main stakeholders could be not only the government and district health, but local shires and even communities, and discuss the merits of a minimum guaranteed income where appropriate, because the business has run down. We need to somehow get... and we need to work closely with representatives from our communities. And thank you for the opportunity.
Thank you. Thank you for that. I very much agree with a lot of what you said regarding recruitment. We do have to think outside the square, and the Local Health District Board is very, very aware that workforce is probably our biggest problem, because unless you've got workforce in the way of doctors, allied health, nurses, all of these people we need to provide services. I'm a director, and one of my other hats is I'm a director and former chair of the New South Wales Rural Doctors Network, which is a workforce organisation funded by the state government. And we are constantly looking for new ways to try and improve recruitment, and are now expanding that organisations into allied health and nursing. So I take a lot of what you said on board, and I certainly would be happy to take your comments to the Rural Doctors Network. I think we as a district board will be working much closer with both the Medicare locals and the RDN in order to make sure that we try and get more people over the Great Divide. I actually left a crumbling economy in Wales before it started to crumble, but I feel very strongly that we don't really market the advantages of living in rural New South Wales, not only to overseas trained doctors, but also to Australian graduates. And we really need to try and improve their opportunities to come out bush. And I think in particular, and that's something that's very close to Joe's heart, I know, is we've got to try and get more training for specialists out here as well, because if you get them out here and they realise what a great lifestyle and what opportunities there are clinically, they're more likely to stay. So it's a really broad spectrum that we've got to hit, but workforce is very, very important in the board's thoughts. Thank you.
Thank you.
Thank you. Detective Inspector Rod Blackman's my name from Marana Local Area Command. I'm the crime manager of this area. And firstly, thank you, Minister and distinguished guests, for coming out to address the community and visiting our lovely city. One thing that's very near and dear to my heart, and certainly I think I speak for the rest of the crime managers in the Western region and those that are responsible for serious criminal investigation. An issue that has been well ventilated over the years, however, to date we've seen absolutely no traction in terms of progress, is the unavailability of willing general practitioners or medical professionals to perform sexual assault kit investigations. I've been here for about 3.5 years. I've worked in various locations around the state. I've worked in Western Sydney, I've worked in the North Coast around Taree, and I've never seen a situation quite as bad as it is out here in Dubbo. Now, considering that we've got a very, very progressive town and we service a very, very large portion of Western New South Wales, I'm keen to know whether any progress has been made by way of the funding package that has been offered in terms of actually getting practitioners motivated to perform what I believe is a very moral and a very necessary function within the community.
Thank you for your question. Lynn.
You're correct, there is a new package out, and we're very lucky that 3 doctors in Dubbo have agreed to go to Sydney to be trained, and they're in Sydney now. So we're hoping that the 24-hour service in Dubbo will be up and running as quickly as possible. We're also working with the Ministry to look at alternate options of how maybe we can do outreach. So we're in early stages of discussing that, but it looks very good on the horizon for this area.
Thank you.
Right. The next question is close to my heart, so we'll give her...
My name is Vicky Canalisi and I have a background in nursing. With regard to the retraining of nurses who have been out of nursing for an extended period of time, many nurses have left nursing to have a family, and as I'm sure you are aware, they now have to retrain for 12 months in Sydney at a cost that many of them can't afford. There are 3 problems. One is the cost of the course and the cost of living in Sydney for 12 months. Then there is the time, the 12 months away, and then there is the fact that they're being removed from their family and often young children. At a time when we need more nurses to come back into nursing, these factors make it very difficult, if not impossible, for rural and remote nurses to retrain. So what I want to know, are there any plans for this to change, and if so, what changes?
Thank you. You're right, nurses are very, very important to us right through the system, and can I say I've been really pleased to be able to welcome the new graduate nurses that have just joined our hospitals this last week or so. We have over 2,100 new graduate nurses starting in this month, which is absolutely fantastic. But you're right, we want to enable all people who've done nurse training to come and work in our hospital system. There are, for those who have been out of the workforce for some time, we're talking registered nurses. For those who've been out of the workforce for less than 5 years, which is most likely those that have taken time out to have families, they can register through a Nurse Reconnect program, where they do that at their local hospital. They don't need to go to Sydney. For those who have been out of the workforce from 5 to 10 years, they do need to do retraining. It's not 12 months, it's 8 weeks, and 4 weeks of that is actually offered through the College of Nursing in Sydney. Now we're trying to come up with alternatives that would make it more available for people in the country, but they are the only accredited provider. The New South Wales government doesn't do this. This is a national requirement to do with the national registration. It's called recency of practice. And the College of Nursing is the only agency that's put its hand up in New South Wales saying that they're prepared to do this training. We've asked universities, we've asked others, they're the only ones. The cost is $10,000, in acknowledgement that that is quite a sum for people who've been out of the workforce to find. The New South Wales government is offering scholarships worth $6,000. So we brought it right back as far as we can to make it affordable. Some of those scholarships are still available, so if you know people who would like to have more information about that, please see us later. And you should also know that under the new national registration, there are many nurses that had registration that were not practicing. And under the new scheme, they can still retain their registration without having this extra training if they've been out of the workforce for some time, if they don't intend practicing. So they can have their registered nursing qualifications recognised, but it will be a non-practicing recognition. And I know a lot of nurses are very proud of their background as registered nurses and they want that. So there are lots of different options, and I believe that we're trying to accommodate all those that we can, and I look forward to many of those nurses who've been out of the workforce coming back, because it's those experienced nurses that are going to be very important in helping the newer graduates come on board. So thank you for your question.
Thank you. Nola Honeysett from Dubbo Health Council. I've received a fax from Bernadette Underwood, who is on the Barradine Health Council and also Dubbo Health Council. She's a very passionate advocate for her community, and she has written this to Mrs. Skinner, and it is also on that subject, so I don't know whether you want me to hand this or read it, but it's certainly another angle, and it concerns her greatly, this retraining. So, do you want me to read it?
Yes, yes.
All right. Is it Bernadette Underwood's words? As a nurse from an isolated area and who incidentally returned to nursing after a very long break and then worked for many years, I cannot believe that the government would support a new method of return to work program. To expect nurses who have been out of the workforce for 5 years to have a family to do an 8-week course at a cost of $10,000 is unbelievable. It was amazing to hear on ABC interview with the Minister making light of the problem, almost as though it wasn't a problem. There will be scholarships and we hope the training will be done in regional areas, she said. As though this would solve everything. These people have done the fundamental training which they are likely not to forget in 5 years. They are young women, very often trying to buy a home, so where does the spare $10,000 come from? And how are they to leave their families for 8 weeks? Are you looking at having no nurses and a breakdown in society as well? Why not have a practical return to work program where they work at the hospital they want to return to for a short period? They work under supervision with minimal pay. This would assist with the shortage of staff and gain extra experience. General nursing doesn't change, just the technology and medication, so time could be spent on upgrading these skills. Conditions now for nurses returning to work are difficult enough, and the role of enrolled nurses has become much more difficult as well. Why not try and make nurses' lives easier? It seems to be hard enough to keep the nurses we have. Let's focus on common sense, which really doesn't seem to be very common anymore. And God help sick people as there is a further shortage of nurses. As I said, Bernadette is very passionate about it.
Okay, Nola, I think the Minister answered that. One thing that I might add to that, in my previous role at the University of Sydney, the School of Rural Health, we had a lot of tuition which came from Sydney, in fact came just down the road. Why can't we establish some sort of mechanism, with the APRA, where the tuition could be delivered locally, admittedly with all the correct curriculum, all that, and it would alleviate a lot of this problem.
Look, I'd be delighted, Joe, if the university would take it up. We've raised it with them and there's been no takers. I'm afraid it's to do with insurance that's making it so expensive. This is not something that I dreamt up. This is a national scheme that all jurisdictions have signed up to. And Look, there is the Nurse Reconnect program that is done at the local hospital where you do that extra training. But for nurses who've been out of the workforce for 5 to 10 years, it is believed that it's needed, that it's necessary for them to do retraining, first of all in a theoretical 4 weeks at the college, and then 4 weeks at the hospital where they've been able to get a placement. So we're trying to make it as easy as possible. I don't underestimate the value of these more experienced nurses returning to the workforce, and we're trying to, with our scholarships, reducing the cost down to 4,000 instead of 10, trying to make it as easy as possible. If people still can't manage that, I'd like to know about it, but will you please convey to Bernadette my concern that people really do understand it is about ensuring that nurses are up to speed with modern technology. My mother was a nurse. There's no way that she would have gone back to nursing without doing refreshers. And many of the nurses that I speak to say the same thing. They don't feel that they need that catch-up. And we're trying to make it, as I said, as easy as possible. If, Joe, you can persuade the clinical school here to provide it locally, I'll bless you even more. Thank you.
Thank you.
I'll take the challenge on.
Phyllis Miller from Forbes. Gillian, I think you'd be disappointed if I didn't ask where we're up to with the Parks and Forbes Hospital. And that is my first question. My second is, you are aware through Centroc that we have done Beyond the Ranges. It is an initiative to try and attract workforce beyond the Ironstone Curtain. It had a lot of resources in it. It had Greater Western Area Health, there were university, TAFE, local government, health professionals that put that together, and I give you the invitation to give that to our local Western Health Council to have a look at. I'm sure you most probably would be aware of it, Dr. Williams. I think that there's some merit in that for doing a pilot somewhere in the state and seeing just what benefits we get. Now that's a small investment by either the state or federal government to get that up and running and online. But the hospital.
Minister.
Thank you very much, Phyllis, and for also always warmly welcoming us to Forbes. I think I've visited Parks and Forbes along with Troy more often than I've visited any other smaller country community. Great drive out there. Look, we've made a commitment, as you know, for the initial funding for Parks and Forbes Hospital. Parks to be a brand new hospital, Forbes to be redeveloped. There's one management across the two, and work should start on that in our first term, and we're looking for continuing funding beyond that to complete the projects. It's the first time, look, I can remember Phyllis coming out there, oh gosh, in '95, I think, first of all, and then when the hospital was promised so many times to that community, and which is why I was absolutely adamant we were going to put Parks and Forbes hospitals in the budget this first term, and that's where they are. So you can watch this space. We'll be making Parks and Forbes redevelopments happen. In terms of your workforce ideas, yes, we will pass that on. There will be some very good ideas in that. You should know as well that Melinda Pavey is assisting with the development of a health workforce plan for 10-year New South Wales Health Workforce Plan. There are a lot of initiatives that will be looked at in that. One of the other things that we've done, and Robin was there when I spoke at the Rural Doctors Network, Rural Doctors Association Forum on doctors, on the pathways we have for rural practitioners. So there's a lot of work that is being done to try and understand how we can better attract doctors, particularly to country communities, but not only doctors, to allied health professionals, nurses and others. And one of the great things I learnt when I was in Broken Hill yesterday at the clinical school there is how they really... This happens when you get isolated communities. They're inventive about how they work together, about how they share each other. They've got facilities out there which are sharing doctors, sharing allied health professionals, so they spend 2 days here and 2 days there. So there are innovative ideas that we need to work up and new patterns of people working together, doctors, nurses and others. And I think that it is, as Robin said, one of our greatest challenges, but I'm convinced the solution to it is going to be in country New South Wales. Thank you.
So this is the last question, then we'll have a break. Oh, yes. Thank you, sir.
Good evening, Mary Lovett and Jenny Eade from the Mudgee Health Council. We just wanted the opportunity to bring to your attention a rather large gap in the service that's provided. Once you're a patient in a hospital and you sign out, you are then generally on your own. In these isolated areas that we live, lots of people may have people who will pick them up, take them home. Some of them might belong to ambulance services, but there's a hell of a lot of people who just get stuck once they've been out of the hospital, signed out, and they're on their own. I'm looking to ask you to fill this gap where people who don't have the funding to actually get themselves home, like just to travel from Mudgee to Hargraves is $100. People in those areas just don't have that sort of money, and all around our small areas. So I'm just asking if you might consider looking at this issue in depth, because it's a really big issue.
Thank you for the question. Thank you. Minister Skinner will answer the question.
Yes, I'm also looking to Robin there because I think that's totally unacceptable. Patients being discharged without a proper discharge plan and without care being taken to ensure that A, they can get home, and that B, they've got the people at home or wherever else to help them. So that is a very important aspect of discharge planning when a person's been in hospital. And as time goes by, in fact you talk at many hospitals where they actually start discharge planning on the day of admission. So they know, predictably within a reasonable time frame as when they're likely to be sent home, and then can help them organise the support that they need to get home and then to be healthy and well at home. But that's something that the district will be taking on board as well. Can I say I've been to Mudgee, lovely hospital, fantastic staff there. One of the great problems in Mudgee, I was told, is again this lack of GPs in the town. So that what happens in the emergency department there, which is run by GP proceduralists, all the people who can't get appointments in their rooms come to the emergency department to be seen by the GPs. That's a real challenge for us in trying to ensure that our hospitals are not just a substitute for a GP's rooms. So thank you.
Good evening, Minister and everybody else. My name is Christine Corby. I'm the CEO at Walgett Aboriginal Medical Service. I also hold the position of the New South Wales Aboriginal Health and Medical Research Council, which is a consortia of 50 Aboriginal medical services across New South Wales. And I'd like to congratulate the Minister for her commitment to the partnership with Aboriginal medical services, and we're pleased to see things progress both at a state level, regionally and locally. Problem-solving approach. I'll bring up the problem first and I've got the solution. Commercial flights to Dubbo, from Dubbo beyond. Bree, Burke, Walgett, Cobo got lucky. 2008 they ceased. For Walgett, we've been operating as an Aboriginal health service, treating non-Aboriginal people as well, so let me get our history right. 25 years, and we see we've got about 80 staff and visiting personnel covering respiratory physicians, podiatrists, dentists, doctors, mental health counsellors, speech therapists, dermatologists, midwives, Australian hearing and drug and alcohol counsellors. So since 2008, when the commercial airlines ceased in our neck of the woods, because Walgett auspices Brewarren Aboriginal Health Service as well, it's cost us per seat on a a charter flight twice the amount up to last year for the original commercial seat. So instead of $200 per seat, it was $400. We were calculating it and trying to review our financial predicament. It's going to cost us $600 per seat from Dubbo to Walgett. I mean, you can fly to Perth for that amount. However, this is the situation with rural communities. I suppose the solution is, and I welcome, and I'm very pleased to hear there's going to be a review of aeromedical services. Certainly us as Aboriginal Medical Services, I'm sure we're going to be invited to contribute to that. But I suppose a solution would be, why can't we consolidate the aeromedical services that go beyond Dubbo? When Minister Humphries was in opposition, and he was kindly supporting us back in 2008, he said he actually did an audit and there were more planes chartering after the commercial airlines ceased than there were. So it's just crazy, and whether someone, be it the RFDS, would like to take that up and try and consolidate. Reduce the seats that we all fly around and there's a milk run, I don't know. But there's got to be a solution, and maybe the review will identify that. But at the same time, it's a real issue for us as an organisation, because with the people that we are flying in, we're actually looking at going to Narrabri, which is only 2 hours from Walgett in the dry, to offer reduced services. So it's impacting.
Can I clarify, is this for patients or for healthcare deliverers?
The doctors, the dentists, the podiatrists,
Okay,
the people,
thank you.
let alone the patients.
Thank you, yeah.
Yeah, that's another story. But so Minister, we'd welcome to be involved in any review for our rural communities, and I see that could be a solution in the short term while the review's being conducted, seeing that there are a lot of air services on the ground.
Thank you.
But thank you.
Minister Skinner will take the question.
Thank you for that, Christine. I know we've discussed this before, and it's one of the things that I was discussing with Clyde Thompson at the RFDS, and certainly something that I'd be very happy to put on the agenda for part of this review. And if you've got anything written, Christine, please give it to us, because I think what you're talking about is very typical of the kind of problem that we can solve by much better coordination of services. You know, we've got planes flying people. At the moment, the flying doctors do a wonderful job with outreach clinics, and it seems to me that it's the kind of thing that we can extend to you, so that you've got those services that you need. And I'd be very happy to take on board those concerns of yours. So thanks, Christine.
Thanks very much for the opportunity to speak. Barry Malone, Chairperson of the Golargan Health Council. I think it's about 13 or 14 years since we last come together, Gillian. I'd like to thank you for your support back then. I think it's fantastic. You're such a resilient person. You lent a big help back then. Here we are, you're now the Minister for Health, and I think we're on a real winner with a person that can stick to a game like this for that long. It was interesting to hear Dr. Williams speak exactly about, in the early stages, about issues like what Golargan have as far as poor health and everything else like that. What I'd like to sort of bring to the panels, not anybody in particular, but I think probably health in general, that there's got to be a bridging not only between health delivery to the community and that, but health and the businesses in those small communities. Currently, Golargan has one supermarket, which the hospital used to support wholeheartedly years ago. We're down to the stage where there is absolutely nothing from the hospital purchased at, or very, very little purchased at the supermarket. The backbone of all health in all communities is a reliable, good, healthy food supply. If you don't have that, you won't have a healthy community. Both federal and state government have a massive investment in places like Golargan. We don't have a community car, and there's very little transport available, and a lot of people, if they had to travel for their source of groceries, they wouldn't do it, and consequently we'd have even bigger health issues than what we already have. Our supermarket supports, that's the first port of call for any fundraiser. That particular family has had a massive input into the hospital. They've had family there in the actual hospital for over 30 years. They were on every committee. Now there's nothing bought at the supermarket. They've dropped off the hospital board or the health council, and there's other people that feel the same way. I've been in the chair job for 13 since we turned it around and got the new MPS there, and we're struggling to get people to come on because all the services for health around the hospital and that come from outside, and in big ways too, you know, and it's very hard to get local people interested in coming on onto the council to keep us going because there's just that much stuff sourced elsewhere.
So the comment you make is the need for local hospitals to interact with local communities, to, you know,
yes,
and source some of their supplies locally.
Yes, that's exactly it.
Who would like to take that?
So I can't comment on your exact situation at Glargenbone, but I will investigate and get back to you. But on the whole, we usually try to buy in the local community because we know how important it is in the local community, and that the local community usually give to the hospital and other things anyway. So I'll investigate that and get back to you if you give me your details before you leave.
Thank you, Lynn.
Quick questions.
Can you?
There was a.
Can you then give your name and who you represent?
Sister Mary Trainer.
Oh, how do you do? Yeah.
From Orange. I chair the Community Reference Group for Mental Health, Drug and Alcohol Services. The MOU, Memorandum of Understanding regarding chaplaincy, was signed off, and we said whoopee, and what a marvellous thing has happened because it's finally come through. Whoopee. However, I'd like to ask, maybe it's Professor Mary, I don't know, someone might be able to tell me what provision exists for the payment of stipends for chaplaincy. There are, in lots of places, the big hospitals, I'm not talking about little country hospitals, they don't need paid chaplains. They know that, we know that. But there are probably two or three big hospitals that we have, and it appears there's no funding. Would somebody like to respond?
Who will? Okay. Well, up to Hannah. That's right.
Well, I'll definitely take that on notice. As you may know, Sister, of course, I've spent a large part of my time in the Catholic healthcare system where we do pay stipends for chaplains, but that was under our own private auspice. And I have to confess that I'm not sure what the arrangements are within the public sector, but we'll find out for you, so if I can get your details. But I would like to commend the chaplaincy MOU because it is a very important part of people's experience when they're in hospital, because it is a time of distress, and as well as people having immense physical needs at that time, there's a lot of other needs, both emotional and spiritual, that need to be attended to. So it is something that we do take very seriously, and I'll answer your question, find an answer on your question on stipends.
Thank you. Second question. A while back, the entry to Bloomfield Hospital from Huntley Road was arbitrarily shut. Now, there's been a lot of agitation, a lot of politicking going on. However, the thing is still shut. Now, what's it affecting? It's certainly affecting the roads within the hospital. They were so full of potholes you nearly took your life in your hands. The traffic coming through to all those sporting things they have there on the grounds, taking up a lot. So why is it at a stalemate? I don't know who'd like to answer that.
Lynn will answer.
Mr Mary, as you know, when they built the hospital, one of the conditions was that that road had to close.
Yes, but there was no consultation, was there?
That was part of what was in the DA and the council, was that that road had to close. So that's why it's closed and that's why it hasn't reopened.
Well, it's ridiculous that it's opening.
Sorry, but that's part of the rules that we had to follow.
Well, who made those rules?
It's a council, apparently.
I just had a note handed to me from the local member, Andrew
Oh,
G,
good.
and it was raised while I was in Orange in December. And I understand that Health Infrastructure is currently talking to Orange City Council about the problems that you've very well articulated. And I think with pressure from people like you, something might happen.
Well, I do hope so. Now, can I ask you third
Yeah, the first question, yes.
Three.
The trinity of questions, yes.
Why is it that people who have a diagnosed mental illness, who have lived for many years in registered boarding houses, and some of whom have recently been arbitrarily and summarily removed, are being cared for by intellectual disability services? Now, what the dickens is health doing? I was going to shoot this one at the Minister for Mental Health, but he's not here. So I think we'll shoot it at the Minister for Health. Why are those mentally ill people, some of whom live here in Dubbo, under the care of disability services?
Thank you, sir. This is very, when I go to the pearly gates, can you be my advocate?
Sister Mary, I'm quaking. No, look, I'll have to take the note. I'll get Kevin to provide an answer for that. Yeah, really, that's the best thing I can do for you. If you want to send
Because
the
when
question.
you write letters to people, all you get back is a thing, your letter is from some secretary or other, your letter has been received, doodle-doodle-doo, and that's it.
Well, I can assure you that having heard you today and how forcefully you put your arguments, you'll get an answer.
Sir.
Thank you, Minister, for first of all, Desmond Murray from Mayor of the Lachlan Shire. Thank you, Minister, and your team for coming out in the country. We do appreciate it, and it's great that we can catch up with you. Lachlan Shire, I'm just going to follow up on the Tottenham issue, which encompasses in our Shire. And I'm going to put a suggestion, or not so much a suggestion, perhaps an idea which I feel that would solve the immediate problem until such times as the local health council or district can recruit a doctor. Now, you've heard what's happened there, but there's plenty of room there and scope there for a full-time doctor. We've had one there for many years, and we've been looking for one since 2007. So that's 5 years. We've had a few people come and approach, and we were led to believe they were coming, and then they disappeared again, and this has been going on and on. So what's happening is we're going to lose the hospital. The Shire has an involvement in that. We put money into the surgery, which is incorporated in the new centre there. So it's important for us as well as the community. My suggestion is that in Carnarvon we've had those problems for years, and as you are aware, we contracted Oka Health to supply our doctors, and this has started to work. And as also you'd be aware, they have quite a number of other areas around the state also. Why shouldn't why couldn't the local health council, Western District Health Council, contract Oka to put a full-time doctor in there, whereas they seem to be able to find these doctors? It might take a little while, but they will obviously find one. Yes, you'll say that'll cost some money, but what's the cost if you don't? That's the question you've got to look at. And that's what I'd like to put to you. Secondly, just a second question on just on the capital works. We as a council have had to build new houses, new surgeries, supply cars and things to look after our medicos, doctors and things right across the Shire, not only just in one town but in 3 or 4. Our local hospital or nursing quarters at Condobolin and Lake Angelico, which I appreciate has been shifted into Murrumbidgee, but was still under the Western District before. They are nearly impossible to live in. How are we expected to get nurses if we can't have somewhere for them to stay, and that is acceptable these days? And this is a problem that's been getting put off and put off and put off, and I'd just like to draw that to your attention that it is pretty important.
Again, you know, the old workforce issues. I think, Robin, yeah.
Yeah, thanks for that question. I think, again, it comes down to workforce is such a fundamental issue. What I'm heartened greatly by that we have now gone to a local health district with a board is that I believe that we'll have much more flexibility about how we can address these things. Under the old system, there were very tight constraints about what could and couldn't be paid, and what could and couldn't be invested in. And I think that we very much see that the vision for our communities is that we need to get workforce sorted out, and that's probably our greatest priority. And as I said, I'm heartened by the fact that I think that we will have much more independence and accountability to do that thing. And I think that forming partnerships with local government, with other agencies, to come up with local solutions is what we need to be doing. And I'd much rather we were paying clinicians of all sorts more money themselves rather than paying third parties. So, you know, that's something that I think is going to be very high on our priority, and I would very much welcome your suggestions if you want to drop me a line so that we can incorporate those into our workforce planning. Workforce planning is fundamental, and we've got to think outside the square. Yeah, and that goes for the nurses as well. I mean, there's no point having a hospital if you've got a doctor there without nurses to support and work as a team. So this is fundamental, and it's something that's very high on our priorities, and that across the whole clinical spectrum.
Again, I remember being at a meeting where people were arguing about doctors and nurses and there was sort of, you know, what they cost and all this sort of nonsense. And I said, look, can I remind you that without doctors, you know, this becomes a nursing home. Without nurses, this becomes a pile of bricks. I know it's an excellent yes minister scenario where, you know, the best hospital is the one without patients, but that's not what we've got to do. So the workforce, and I think the board's really aware, you know, of that and really works towards that. And I think it's going to be one of the big priorities for the next couple of years.
Thank you. Thank you. My name's Gary Brown and I'm here to represent Cabonne Council. This is also a workforce question, but first off, I'd just like to say that last year two very close relatives of mine were cared for at Orange Base Hospital, and they both suffered serious medical emergencies, and I couldn't be more pleased with the care they got. It was totally astounding, and they had very positive outcomes, and I'd just like to congratulate our health services on what they were able to do for them. There's also...
Thank you.
My pleasure. There's also other patients who sometimes get treatment for either medical emergencies or serious operations, and they get sent to smaller regional hospitals or district hospitals to, I guess, recover for a period of weeks before ultimately being discharged. They also receive very good nursing care in those situations, but the problem is they don't always get the rehabilitation services they need. The physiotherapy isn't there as much as it should be, and I'm aware of some instances where patients have suffered very negative outcomes because they haven't been able to access the rehabilitation services they need in those smaller hospitals. Is there anything we can do about this?
Well, I guess in many ways it's been addressed, but I'm sure, you know, the workforce issues again, you know, I'm happy for Robin to reiterate, but it's...
I think the points you raised is very, very important, and it also moves on to the role for our smaller facilities. I mean, I work in Molong. We take a lot of patients back from Orange, which takes the pressure off the acute services in Orange, and I think this is a fundamental, important use for our smaller facilities, because it provides a service in a small town. It provides an interesting work for the nurses, which makes them more likely to want to work there. And it's a focal point for our communities, so it's very much important that that role is expanded. I agree with you completely. We need to have more rehab facilities, and that again comes down to workforce. But with this greater autonomy that we have, I'm hopeful that we will be able to make a real big dent into that problem, because if we can make it an attractive package for doctors and allied health and nurses to work in a smaller facilities, then I think that will alleviate a lot of the problems that we're suffering. So that again, it comes down to workforce.
Thank you.
Pam Bell, Chair of the Peak Hill Health Council. My question relates to the MPS for Peak Hill. Peak Hill Health Service operates out of a building erected in 1904. Over the years, minor refurbishments and a dedicated staff have kept this health facility open and functional. Minor refurbishments will not enable this building to continue to meet audits. Peak Hill Health Service has been identified as a potential MPS site, and we have again been assured over a number of years that we are high on the funding list. With the announcement tonight that our funding model is changing in the state anyway, and I do acknowledge there are no federal representation here, can we hope that the promise for your support still stands?
Minister Skinner.
Absolutely. Peak Hill is one on the top of not just this local health district, but the state priorities in terms of multi-purpose services. And as I said previously, we have put in a submission to the Commonwealth for some funding for those MPSs. So keep fingers crossed that that's forthcoming and you will get your MPS.
Thank you. Thank you.
I'm Sue Ellen Kennedy. I'm a member of the Blaney Health Council. I'm also the Secretary for New South Wales Meals on Wheels. My question is, just recently, I know at our hospital our meals went from $3.50 up to $11.50 for a package. Why did that happen when health is supposed to be putting in preventative measures for the community? Isn't nutrition a very important part of that? They're not subsidising us anymore. We actually have to ask our clients for $11.50. We have to pay for packaging, so we have to actually charge them about $12 or $13. Fortunately for us, it's too late. We actually went to the local hotel and they said that they would provide us a package for $7. Why is it that the hotels can provide meals to those that can access them, whereas health were quite happy to charge $11.50? It was supposed to be a standard price with all New South Wales Meals on Wheels services. Some were getting charged $10.50, some were getting charged $11.50, some were getting charged $13.50. I find it very, very unfair to have to expect a client to pay $12 when at the moment I'm getting them from the hotel, I'm charging $7, I'm paying $6, so I've got an extra $1 for containers, but I can't see how that the meals at the hospitals could cost.
Thank you. Yeah, I wasn't aware that we provided Meals on Wheels for a lot of the services. Yeah. I knew for some, yeah. But, yeah.
Well, the thing is, it's okay for us, but there's a lot of little places around now that have nowhere else but the little hospitals, and they can't access meals from anywhere else. So
yeah, that's true.
They've got no choice.
Obviously, you were part of the review. There was a review done of Meals on Wheels, and we looked at having cost recovery. So your site must have been one of those. So you've now moved across to using
a hotel. Yeah.
Yeah. So.
Which I think is a shame, because we're supposed to be. We're all in the same industry. We're working with health. It's preventative. They should be health services should be supporting us because we're keeping people out of hospitals. So we're saving you money in one way, but then, you know, you're happy to charge us all this money that we have to pass on. I really think it's pretty lousy of health to do that. I was very, very angry. You know, I'm not the only service, I'm a part of a Western region. It happened in many of the other services. Some had no choice, but they have to pay that much money to the hospitals because there's nowhere else to get their meals. So these elderly people are having to pay $11 and $12 or $14 in one spot for a meal from the hospital.
Okay.
Yeah, we're working together. Why did this happen? What's going on?
Yeah. If you give me your details later, then I'll have a talk to you about that and we'll have another look at it.
Thanks.
Thank you. Okay.
Don Dean, Chair of the Cabonne Health Council. Now the Cabonne Health Council is made up of 6 or 7 small communities, so that we're doing pretty well in some and some we're not doing so well in. And my question is, we were promised by the previous government, which I don't hold Julian responsible for, but our previous government promised us a new hospital if we would surrender our old one. We surrendered the old one, and so they then gave us half of a hospital consisting of the stage 1. Stage 2 never happened. Stage 2 never happened, and my question is, why didn't it happen? And the present government cannot be held responsible for that, but we were promised, we were allocated the money, $4.5 million, 1.8 million was spent on which turned out to be a community health centre. Now, we're still not happy. We were promised our 10-bed facility. We want it.
So we might ask, who would affect that, on what stage you're at with that?
Yes, as you know, Don, I mean, you do have the services of a GP, Dr. Zambo, who comes out to Kudal from, and he also comes to Molong now 3 days a week. I think the models of care have altered over the intervening years, and it's not so much about beds as about services. And what we are trying to do through Health One in Molong is to have an integrated service with integrated records between Yeovil and Molong, probably Manildra in the future, and Kudal, where the inhabitants of those villages will be able to access doctors in all those villages, and their records will be linked. We obviously want to try and to bring more outreach services to those communities, and that's something that we would like to see expand from the community perspective. But it's not so much about the facility, it's not about the bricks and mortars, it's about the services that you provide. I mean, people talk to me about Molong Hospital, and in the old days they used to do major surgery there and tonsils and everything like that. The world has moved on from that situation. I personally would never want to be operated on in a facility like that, because state-of-the-art stuff is in Orange. And I think that what we've got to try and do is look at a different model of care, not based around beds, but about services. And I think that's what's important. And certainly the people of Kudal are well serviced by Dr. Zambo, and that's something that we would be looking to continue.
Look, I agree that the medical services are good. Dr. Zambo is well thought of and well received into the community, but we got a $1.8 million health centre, which is grossly underutilised. The services are diminishing. They're not improving, they're diminishing, and which we're not very happy about. And you can see a notice on the door. Centre closed today due to staff shortages. So without being, nitpicking or one town against the other, but that staff member that works at that centre has got a notice on the door, staff shortage, centre closed. But that staff member that usually works this facility pops over at Health One.
Yeah, I think again the allocation of resources is something that we need to look at. I'm quite happy to have this discussion with the health manager for Cabon to see if more services are needed. Certainly, I'm happy to look into that personally, because I think it's important that we try and provide services as close as possible to where people live, and I'm more than happy to look into that personally.
Thank you for that. But that's the other part of the what I was going to say is that, as I said, the services are diminishing, and one centre is being used to wipe up the other. Like notice on the door, centre closed today because of staff shortage, but that staff member is in another facility. Well, why is it that staff member's got to go to another facility? Why can't it stop in the facility it belongs to?
Well, you might get that discussion there with Robin, because he's involved in the health delivery in that area. So he has both sort of a personal as well as a district hat that he can wear and discuss that with you.
Yes, but
Thank you.
We haven't let up on the completion of our facility. Stage 1's there, we want stage 2. And we haven't let up on that. I've been talking to Andrew G, and we'll be pursuing that one rigorously.
Okay, thank you.
Stuart Leckie, I'm here on behalf of Chronic Pain Group in Dubbo. As a group, we've had several meetings, and later on in the year we hope to hold our first self-help seminar. We also have a petition circulating, raising signatures for those people that are in chronic pain in Western New South Wales. And I'm here on behalf of the group to ask the Minister if she's able to provide a chronic pain service for the people of Dubbo and Western New South Wales. As she would be aware, there are no services this side of the mountains. Thank you.
Thank you.
Thank you very much indeed. Pain is a topic that has strong personal interest for me, which is the reason why we have set up a task force to develop a pain management plan for New South Wales. We've received early drafts of that plan. It's being considered by the Ministry, and you can expect to see the results of that plan put out with some implementation ideas later in the year. Can I tell you that I have a very warm relationship with Professor Michael Cousins at Royal North Shore, and I know the wonderful work that he does, and his and the work of others in this field, concern about trying to get more services out beyond the Blue Mountains. So it's something that will be considered in the context of that plan. Thank you.
Thank you.
Thank you for that. And like I say, having been on those sort of committees and bodies that investigate those, it's really taken super seriously. It's not swept under the carpet, because it's important for the patients, but also reflects on all of us. And I think it's important that that doesn't happen. And it really is taken very seriously.
Bill Kelly from Coonabarabran. Coonabarabran Hospital, of course, is my keen point of interest as far as doctors are concerned in particular, and of course nursing staff. I'll cut it very short. The Environmental Medical Centre have done a lot in the past, training, in getting involved with the trainee doctors, visiting Coonabarabran and coming there from time to time over several years past, which I believe is a good idea. One day, one or some of those might come back and be a local doctor at Coonabarabran. But we really need to try and apprehend the impression I have in particular, and the impression of quite a few people I've spoken to. The place is gradually being closed down, and that's not what we want. You're not going to encourage people to work there, whether it be nurses or doctors, if it looks like it's in a dying situation. And that is the impression that comes back by talking to some people who've been in the place of late.
Thank you. Who'd like to take that?
There's one other point I would like to raise, and seeing the time is as it is,
Yes, sir.
I'll get out of the way.
We'll have one more question and then we'll finish.
How long do we have to put up with the threat of insurance as a deterrent to having clinicians, etc., working for us? They killed off all the obstetrical nurses very quickly a few years ago, probably started 10 or 12 years ago, by the threat of being sued in case something happens when you're delivering a baby. Admittedly, some changes had to take place, and modern medicine have led us to the need of lots of operations that used to take place at Coonabarabran. But there's still a bit of a time, I believe, for some kind of a turnaround that needs looking at. Okay. Thank you very much.
Who would like to take Robin or?
Yeah, thanks, Bill. Yeah, I'm very passionate that smaller facilities do find a role. I've certainly have no interest in seeing a diminution in the services that they provide. And I think that that's something that we've got front and centre in part of our ethos, because without facilities being maintained in small towns, then the trickle-on effect is horrendous for their communities. So that's not something that I would hope would happen, and I certainly think that as we go into our clinical services planning and looking at all of the facilities, we'll be looking at roles for facilities like Coonabarabran. I've said to many health ministers prior to meeting the present one that I wouldn't work in a small town if there wasn't a facility to look after patients in, because I might as well be a GP in Leichhardt, and I didn't emigrate from Wales in order to be another GP. The real reason we came to Australia, apart from the fact that we felt it was a better place to bring up our children, was that in Wales I was working as just like a suburban general practitioner, referring everything to large hospitals and not doing as much clinical work, the real hands-on stuff that I wanted to do. And that's what is the great attraction of getting people to come and work in smaller towns. What we've got to try and do is make sure that the new cohort of doctors coming through realise how good it is to be doctors and nurses in communities like this. And that again comes back to workforce planning and what we can do about it.
Thank you very much for that. Point is, of course, you particularly, if you were living in Sydney, would appreciate the fact if you've got somebody that's a bit sticky, send them to the local accident emergency department and you're finished.
Yeah.
And there's at least one I know of pretty close to Coonabarabran doing just that. But we have to try and give proper service to the community, if it is at all possible, rather than have to traipse. And some of the elderly people, and my age group's in that, but I'm still lucky to travel. But it costs a lot of money to travel long distances to see a doctor. And we've got to avoid that situation happening.
Sure, I think we've got to
keep some there.
Yeah, we've got to agree, I think, to try and make the hospitals places that the new clinicians want to work in. Yep. And I agree with you, that means that the facilities have got to be maintained. and enhance wherever possible. The other issue that I forgot to address was the insurance issue. I think by and large that has been addressed now by the Treasury Managed Fund. There was a huge problem with insurance with proceduralists and obstetrics. That was in the time of Craig Knowles as Minister, so we've had about four, five, I think, since then. So that has been addressed, and again, it did cause a big problem with regards to putting a lot of the new doctors off training to be GP obstetricians, and I'm very glad that the present government is very committed to enhancing the training of GP proceduralists so that we've got the people on the ground to provide the service, and then we can perhaps look at enhancing the provision of services into smaller towns.
Thank you, Mr. Chairman. One and all involved.
Our final question.
Yeah, it's Cecil C. I'm the CEO for Pavey Aboriginal Medical Service based here in Dubbo. Forgive my sarcasm, but I won't tell you my problems because there is a lot, and I won't ask you for money because I know you're broke. But one of my main issues is what commitment is the health given to Aboriginal communities, especially in a local level. Since the local networks have been in play, hospital networks have been in play, I have not even been approached to for people to come and talk to me about Aboriginal health or anything like that. No MOUs, no partnership arrangements, which is an insult to us. We have been going in Dubbo here since 1994 as an AMS, and it's not only just Dubbo, it's probably all the AMSs around Western New South. It's a very big issue of our concern because everyone is out for the almighty Aboriginal dollar, but yet we're the last people to talk, we're the last people to be asked for anything, especially if it's anything to do with issues, we are the last to ask, and most of the time we're not asked, we're told. So to me where is the commitment going to come from now? I'm not worrying about the past is gone. Let's worry about what we're going to do now.
Good luck. Robin, you could.
Thank you for that. Yes, as I mentioned in my opening address, the closing the gap between Indigenous and non-Indigenous communities' health is very, very important in our philosophy. The consultation process that we need to go through is complex. We don't want to offend people by talking to one group and not to another. But it is very, very high in our list of priorities. Certainly at the Medicare local level as well, the Medicare local is very aware that we must engage and have the Aboriginal health organisations as integral parts of those of the Medicare local, and that goes right up to governance level, so that there will be a governance representation from Aboriginal organisations in that organisation. I think that's very, very important. We're fortunate that we have Pat Doolan on our local health district board who gives us very insightful information. But yeah, we need to talk more, and we need to be very, very inclusive about this, and you certainly have our commitment that this will happen.
Firstly, I'd just like to start off by acknowledging the country and thank you for that warm welcome earlier. The challenge of health and how to fix it all is certainly, as I could describe, as trying to eat an elephant. It's just trying to do it one bite at a time. This event tonight is historic, as it was spoken about earlier. I don't think in a community before have we had this level of access to the Minister, the Director of Health, the Parliamentary Secretary of Health, our local CEO and all our board members here. So this is really an opportunity that I'm delighted as the local member to have welcomed, and may I start by firstly thanking you all so very much for coming, Minister. You are, and have been ever since I've known you, a terrific supporter and advocate for issues in this electorate, and I understand, having spent considerable time with you, that you have an amazing depth of understanding of the issues that are before us. And I know that whilst the challenge will be like eating an elephant, you'll give it your best bite. So I thank you for that. May I also thank Dr. Robin Williams and your team in the board for your participation. I've spent some time with Robin and Ron Dunham, the new CEO, in relation to the prospects of health infrastructure gains here and improved services and the like. And I'm extremely impressed by the commitment of both these gentlemen to the very issues, many of those that were raised here tonight. And I have absolute confidence that together, the local members like Andrew G, Paul Toole and myself, and Kevin Humphreys also, we have enormous access to Robin and Ron, and we thank you for that access and the ability for us as local members to advocate on behalf of our constituents. Obviously some of the issues that you've heard tonight, but there are many more. In doing that, I'd like to thank my colleague and close friend Andrew G for coming, Andrew, and making the effort. I know many people have travelled a long way tonight to come. This is historic. As we try to eat that elephant, I think we need to look at many of the things that Robin highlighted about the advancement and the evolution of health services, about the opportunities that are there to embrace technology in our area. And I think we have an opportunity now to really move away from a position where we used to compete all the time for services from one town to another or from one region to another, to move more into a phase where we can look at providing those services and the very best of them in more of a complementary fashion. And I think that will be the greatest legacy that this government can leave. There's no squirming from the fact that it is an enormous challenge. We have inherited what we have inherited, but we're not going to sit and just look at the lot that's been left in our lap. I think it's been demonstrated tonight just by your very presence, Minister, and all your team, that you are prepared to listen, you are prepared to make yourself available and accessible, and that is of enormous credit to you. And you have the most wonderful Parliamentary Secretary in Melinda Pavey helping you in that quest, who is tenacious, who has taken her role by the teeth, and who is, even in her early days in the role, is being afforded civic receptions, which is just incredible. But I know that's the esteem that you held in throughout this region, Melinda, so I thank you for your tireless contribution as well. So very much in summary, I don't think tonight was ever an opportunity to solve all the problems of the world or to eat that elephant in total, but I think this is just another demonstration from our Minister and the team that are there to support us to navigate that way through that large meal, to help turn the tide of health services and the infrastructure. In a first term of a government, to commit just in my electorate $117.5 million that for 9 years was promised yet not delivered is a massive turning of the tide. It is a great first step. It is the first step, and I think that's always going to be acknowledged. We have a long way to go, but we'll only achieve if we go together in that pursuit. So I encourage us all to do that. Let's complement each other, and if you would join me to please offer a vote of thanks to our panel. And just before I hand back over, I'd just also like to recognise the individual contribution as your MC made by Dr. Joe Canalisi. At every opportunity I'll always buy this man a cup of coffee, not just because his company is enormous and is fascinating, but he is one of the world's greatest guys you'll ever want to meet. His heart is pure, and he's contributing in an amazing way. Thank you, Joe.